I do that more lightly than most, but I haven't broken anything yet, Doug, so that's good. Yeah. I'm going to call to order the December 23rd meeting of the Special Committee on Academic Health for the University of Minnesota Board of Regents. Good morning, everybody. Just a reminder, as this meeting is not live streamed from the West Committee Room, but it will be on the YouTube channel, recorded and on the YouTube channel later today. Quick reminder, too, that the room has room-wide microphones, so make sure you are projecting when you speak, and I'll ask those in the audience to limit conversations because it picks up things very easily. Before we move to our first agenda item, I just want to remind the committee that the financial plan for the academic affiliation agreement between the university and CentraCare Health is before the Finance and Operations Committee today for action later today. As you recall, we approved the academic affiliation agreement here, and then we wanted to make sure it was a sustainable plan and wise plan financially, so that's going through its second review now and approval for action with the Finance and Operations Committee today. So I wanted to let everybody know that as well. With that, we're going to move to our first agenda item. So with a chance for this committee to input to the Governor's Task Force on Academic Health at the University of Minnesota. And I want to make sure that we get an update on that, what's been going on. The task force has met now 4 times since October, with 2 additional meetings planned for this month and then next month. The task force would submit its recommendations to the governor by January 15th, 2024. So it's working on a fast timeline, and we're trying to do a lot for a lot in a short period of time. That's for certain. But I think if anything through this, the salience of what the academic health means to the entire state of Minnesota and the health and well-being of all the people of Minnesota has become abundantly clear. To start, I'm going to invite Interim President Ettinger and Vice President Toller to outline the university's vision for academic health system, which was presented to the task force yesterday. Then I'm really pleased to welcome Task Force Chair Jan Malcolm. We couldn't have designed a person better to chair this and to share her thoughts on the task force so far. With that, I'll turn it to Interim President Ettinger.
Thank you so much, Chair Wheeler and Vice Chair Johnson. I'd like to begin by thanking Task Force Chair Jan Malcolm for joining us this morning and for the important role she's taken on in shaping the future of academic health at the University of Minnesota. Yesterday afternoon, our team presented these materials that you're about to see today to the Governor's Task Force. They outline a vision for academic health future in Minnesota and the university's specific role in it, the case for increased funding from the state, and new initiatives laid out in a 3-point plan. Our goal is to continue to build upon the university's long history of access to excellent health care for all Minnesotans. It's our land-grant mission to serve, and our healthcare education, research, and practices provide tangible examples of this mission at work for many Minnesotans. With that, I'd like to ask our Dr. Jacob Toller, our Vice President for Clinical Affairs and Dean of the Medical School, to proceed.
Thank you, Mr. President, Chair Wheeler, Vice Chair Johnson, Regents, everyone. I'm delighted to be here, and since I'm certain that you are eager to hear from our Chair Malcolm in a moment, I will try to be brief. Yesterday at the meeting, Senior Vice President Franz has presented the vision and it's not recommendations. It's not our task force. It's really governor's task force. So it's more our plan for academic health in Minnesota. It must have been somewhere in the ballpark because we have heard both that it was not enough and that it was a very, very large number. I'd say from my perspective, the meeting went very well. Thanks to Chair Malcolm, especially, her diplomacy is exquisite. The conversation was robust. We started with a panel where we invited 2 of our consultants, Cliff Stromberg and Mark Werner, to talk to us about various models for support of academic health systems. And the bottom line of that is that there is no one structure that works for everyone. So we are probably on the pathway of designing one that's going to be with the Minnesota own imprint. Now, I hope it's fair to say that the task force does support the university and the importance of academic health as a part of an ecosystem of healthcare in the Twin Cities and the greater Minnesota. And it's not quite ready to make the recommendations there, as you said, Chair Wheeler. There are 2 more meetings, and there is a lot of work on the path forward. Recognizing that it's neither easy nor quick to transform the care delivery, we created a platform, an outline that has 3 phases: short, medium, and long term. The short term, we have suggested number 1, $60 to $80 million in academic support for things like faculty recruitment and retention, for interdisciplinary research teams, for enhancement of the interplay of the 6 health science schools and interprofessional work that we are doing, for extending the clinical services that we provide, and especially those that go to the underserved, such as our Cook Center and the primary care clinics. We support the state in looking into stabilization of the University of Minnesota Medical Center, and by various means, for example, by increasing the Medicaid rates and considering physicians and clinicians who are teaching at the whole spectrum, and many other similar ideas so that we optimize the use of the intergovernmental transfers. Because there are many needs in our healthcare system around the state, there is interest, and we support a collaborative look at how we can best use the footprints and potentially programming among various public health systems that we have the benefit and a luxury almost to have in the Twin Cities and in the state. And we believe that the seen in the media, and Governor Dayton was very clear about this. He considers this short-term and urgent. And his calls on his intensity is always a welcome ingredient to our task force meetings. We need to upgrade the hospitals to meet the expectations of patients and providers today, and we need to have a control of them so that we are able to determine the investments and programming necessary to meet our mission as the state's public medical school. In the long term, that's the third part, we have been consistent in saying we need a new hospital. There was a debate over whether the state needs a bigger hospital. I'm not saying more, I'm saying that there are many different ways to look at this, and we all know that the hospitals as we have them here on campus and in the Twin Cities and states are bursting in seams. So we need something different. It's a qualitative rather than a quantitative approach to the same problem. We need a state-of-art hospital so that the patients can get more care in the area where we specialize, which is complex patients. And we need a true ecosystem and a network, not just an island, a network of ambulatory sites to provide the ambulatory perimeter and the referral base for the patients that we can take care of. I will end by saying that we potentially are moving away from the idea that this conversation is about losses or filling a gap. And as Stromberg has pointed out, the academic medical center have lower cost of the total care per episode when compared to the alternatives because of the high quality innovative care and prevention in this. So the only way to reduce cost of healthcare is through innovation, and that's why we are here. So I will repeat, as I always say, that academic medicine is a good business. Thank you, Chair Wheeler.
Thank you. Thank you very much, Dean Toller. And I'll invite Chair Malcolm up to the table here now. Again, so grateful for your leadership. And before we get into a discussion about what else the committee here has questions or actually opinions for the task force, wanted to get your perspective on the task force and its progress so far. Is this on, or do I need to?
You don't need
You don't
You're
need to.
good. It's good? Okay. Thank you, Chair Wheeler. Good morning, members of the committee, President Ettinger, my friend and colleague, Dr. Tolar. It's very nice to see you all. And thank you for the opportunity to get your input for the task force. Certainly, we've had the benefit of Dr. Tolar and Dr. Wheeler's and Dean Delaney's presence on the task force as members, although, and you might know Dean Delaney's actually there, not as one of the two university slots, but as a true workforce expert, particularly representing the perspectives and the criticality of the nursing workforce in our state. And we've been grateful for all of their individual insights, but I know they are also working hard to form a perspective from the university as a whole. I would concur that we are at a really critical point in the task force. We spent a lot of time. I'm of mixed mind on the value of really short timelines. On the one hand, it makes you focus. On the other hand, we're going to be nowhere close to satisfied with what we have learned and what further questions we have. But we have learned a lot. We've spent a lot of time trying to understand what's going on around the country. And certainly, as Dr. Tolar just said, one of the main takeaways from our own research and from hearing from these national experts is that there is no one right model. And it is tempting as it is to say, well, let's just go do what Indiana did or what Vanderbilt did or what Stanford did. The models do not translate very well from market to market. But certainly there are kind of characteristics that we think inform, how Minnesota might go about this. I'll just say personally, I'm humbled by this work. I'm not an expert in academic medicine or academic health by any means, so I've probably learned as much or more than anybody. I'll just start with just a couple of things that I think have been particular challenges for the task force and will be, and you'll see it in our report, which we will begin writing over these next couple of weeks. The first is that obviously academic health exists not on an island, but completely embedded in what I think every single person on the task force agrees is a badly dysfunctional overall healthcare system. The way we finance clinical care, the way we finance education, the way we finance research as a nation is broken. And I think there's been policy discussion about that in our country for many decades. But there hasn't really been, in recent years, nationally or at the state level, enough attention to the very fundamental things that make healthcare so expensive and so suboptimal in terms of the results that it produces compared to others, which is not to say we don't have phenomenal capacity within our healthcare system in this country and certainly in this state. We absolutely do. But that great capacity does not reach all the people in our state or in the nation, and it is not sufficient to actually improve the health of populations just to have great health care. We all know that. Health is something much bigger than access to medical care. And the statistics that have been borne out over decades of health services research just keep getting more and more compelling. That, of course, access to high quality health care when you need it is critical. It makes all the difference in the world. But the best healthcare in the world cannot overcome all of the other factors that overwhelm the influence on health status. And those things are what characteristics of the environment and of human behavior. And so we talk about that a lot. 80 to 90% of what determines health outcomes is not clinical care. It is the quality of education, of housing, of income security, the physical quality of the environment, air and water, congestion, the like. And it's almost counterintuitive. How can that be that clinical care itself is such a relatively small part? But I think certainly Dr. Wheeler, with whom I've had the great privilege of working for many years, and Dr. Tolar as practicing physicians, Mary as a nurse, you all know that what comes in the door into the healthcare system is oftentimes much more complex than what you can fix. And that river of problems just keeps flowing into the healthcare system. And boy, over these last almost 4 years now, have we seen further lessons of the truth of that through the pandemic. I could go on and on about that. That's not our purpose here today. But just making this point, just to underscore at the get-go, the task force members are critically aware of the fact that you really cannot fix, if you will, academic health in any sustainable way without attending to some of those bigger macro forces. The way we pay for healthcare access and healthcare services is a big part of the problem. One thing I would also say is, so health is more than healthcare. Medicine and public health are distinct disciplines that are absolutely interdependent on each other. And one of the things the task force really appreciates is the uniqueness of the University of Minnesota's academic health capacity with all 6 of the health sciences colleges. But we keep, frankly, kind of struggling a little bit in the task force. So wait, now, in this point, are we talking about academic health or are we talking about academic medicine? And I think that's one of the things you'll hear from the task force is a desire to be really clear when we're talking about facilities or funding or educational innovation, that we're talking about all of it. And that the interdisciplinarity of the ability to train teams of health workers is what we need for the future. And we have to have as much synergy as we possibly can between those disciplines and between the medical components of producing healthier people and the other societal investments that are needed. And that does become relevant when we're talking about money, because what happens all the time in American health policy, I'm sure elsewhere in the world too, is that the money hugely flows into the clinical care slice of the pie. Less than 5 cents on the dollar that we spend on health-related things goes into the 80% of the factors that determine health outcomes. And that's a problem if our investments in healthcare crowd out the other needed investments in those determinants of health. And that's a particular challenge because we know that what we're spending on healthcare is necessary. The challenge has always been to find ways to make sure that spending is producing value and isn't being wasted in one way or another through inefficiency or failure to catch problems early enough or to diagnose correctly, all those things. So the things that make healthcare so expensive are not all the fault of the healthcare delivery system, but we need to make sure that investments in healthcare delivery don't crowd out those other investments that are necessary to actually produce healthier people at the end of the day. I belabored this point just to sort of say that's where the task force starts, is with that awareness that we have to keep if the real end goal is a healthier Minnesota, the role of academic health within that is critical. It's necessary, but it's not sufficient. And the same is also true of any other component of the system. Public health is necessary, but not sufficient. I mean, we need both, which again is some of the really great promise of the comprehensiveness of academic health at the university. But we keep coming back to this need to clarify in the university's proposals. When are we talking about academic medicine and when are we talking about academic health? Because we are very aware, Dean Toller mentioned the School of Nursing, some of the great innovations that they've had, some of the partnerships that already exist between the schools, but what we've heard loud and clear is that collaboration isn't really supported by current financial models and by, in some respects, from some of the designs of the way education is done that are driven by accreditation standards that kind of keep things in their silos. So we know we're working against some really big macro forces that we as a state can't wave a magic wand and fix. But we do want to make sure that we're responding to urgent, immediate needs, but with an eye, frankly, to a pretty different model in the future. And we don't know what that model is going to be, but we know it's going to change.
We know that technology, the role of artificial intelligence in healthcare is one of the potentially most phenomenally wonderful applications of AI. But we don't know where all that's going to go. So we have to be thinking about a nimble strategy and an ambitious strategy for the future that really allows for a future model to be much more holistic. One of the things I most appreciate about how the university's proposals have evolved over these last weeks is that greater, I think, leaning in to the need for a community conversation about more collaboration. Like where do we really need to invest more in individual pieces versus sort of a more integrated or collaborative system where facilities might be shared or clinical specialties might be thought of in a more collective sense. Easier said than done. I totally understand that. Just wanted to give you kind of a flavor of what the complexity that the task force is wrestling with. But at the end of the day, our charge is to understand what the state needs to do to better support academic health at the university. We're clear about that, but in the context of really wanting to appreciate and maximally leverage all the resources in Minnesota. So we're working on 3 problem statements, and it took us a while to even narrow down to what problem is it that we're trying to solve. Yes, we want to support academic health, but what are the specific problems? And we've come up with 3. One is that the financing model for academic health leaves some critical gaps. And here's where I think we started out, and the governor's in the governor's thinking and the work, and I know the dialogue with the university was part of like even creating this task force and framing what is it about. The focus from the governor's perspective was very, very, very specifically education of health professionals, the workforce, and the university's role in training the health professionals of the future, not just the docs, but certainly the docs, but the nurses and the pharmacists and the dentists and the public health workers and the veterinarians, all of whom are in critical shortage in our state. We've learned, certainly through this task force process, that you don't get the health professions education without that 3-legged stool of clinical care, a viable, robust clinical enterprise, and a strong research structure, and the virtuous cycle, which Dr. Tolar and others are teaching me about. That it might have been nice to say, well, we're just only here to talk about education, because that's actually what we thought we were going to do at the beginning. But appreciating the complexity of the financing, we've come to have a much stronger appreciation for why the clinical enterprise and the partnership with a partner, Fairview in this case, why that is so relevant to the question of how are we going to train the health workforce of the future. So the first problem statement it reflects that the financing system leaves us overly dependent on clinical profits to support the health professions training, and the clinical profits, just given the way we pay for healthcare in this country and where the incentives flow, don't line up terribly well with the public health goals of the state. The more profitable services are the more technologically intensive, the more highly specialized, again, critical for individual patient health, but not sufficient to improve population health as a whole. So we're looking at other ways of thinking about other ways to support kind of the 3-legged stool, but appreciating the importance of that robust, strong clinical partnership. And even though we are not there to advise or opine or judge what should happen with the partnership between the university and Fairview, the governor was very clear about that. That is a private business relationship in which the public clearly has interest. But we are not the experts on how those relationships should be structured, and we are not opining on that. However, we have found ourselves spending a lot more time on that than we had thought we would, or particularly wanted to. But it is the fact of the environment, and I think we have, as a task force, kind of come to an appreciation of the importance of a partnership and why that is, and I imagine, though we haven't yet sorted through which recommendations are going to go in the report, that there will be support for continuing and strengthening that partnership with perhaps some references to some of what we've learned about other models that seem to be particularly robust from a public interest perspective again. Second problem statement is that we are, given the workforce challenges in our state, we're just not training enough of any of the professionals that we need. We do foresee physician shortages, nurse shortages, public health shortages, pharmacy shortages. I mean, we're already seeing them. It's not theoretical. And it's projected to only get worse, particularly in rural Minnesota, where the workforce challenges are significantly more acute. And speaking of acute, the workforce challenges in acute healthcare are bad. They're even worse in long-term care, which, again, from a public health perspective and what we learned through the pandemic, the acute care system is entirely interdependent on a strong long-term care system to be able to move people through the process. So if we're not thinking about training the workforce that is needed for long-term care, we're not solving the problem. So, and then we've also talked a lot about the composition of the workforce. And is it reflective of the state? Do we have enough? We know the data are abundantly clear that one of the ways to deal with health inequities in health status is to make sure you have a workforce that reflects the populations that are being served. So we want to prioritize growing the programs, being able to train more people, and to train people that are really reflective of the communities. The third, and we'll have recommendations on each of these three problem statements. The third problem statement is, yes, we should grow the workforce, but the reality is there are never going to be enough people to deal with population changes and population growth and everything that we'd love to be able to do. So we have to learn to use the workforce that we have differently, more creatively, more technologically enabled, to get more capacity out of the workforce that we have. And that really calls for a much bigger emphasis, Dr. Toller mentioned this, on innovation in care models and figuring out how do we use this workforce in a more in a way that helps us deal with those gaps that are not going to be closed just by training more people. For one thing, there's a limited number of faculty. For another thing, it's the federal government that sets what that capacity is for through how many residency slots are funded and the like. Well, not exclusively, but significantly. So those are the three problems. Yesterday, we looked at about 60 or so individual recommendations that fit. Our next step is there's some duplication there. We just asked every task force member to do a brain dump of what they're thinking. And now we're going to organize that, pull the common themes together, consolidate. Many of the recommendations are quite similar, just worded differently from different task force members' points of view. So we'll be working on a shorter list in our next meeting on December 20th. And from the beginning, it's been our thought and our goal not to have a formal voting mechanism to say the only things that are going in the report are the things with 75% agreement. We're not doing that. We're intending to put all ideas in the report, but measure kind of degrees of consensus. So how many people are really enthusiastic about this recommendation versus how many people feel kind of mixed about it, or how many people think I could support it, but not until there's more data behind it. So we thought our best service to the governor and the legislature, who are our customers for this, would be to show them the full range of ideas with some quantification of where does the community consensus, at least as reflected by this task force, seem to lie. So that's maybe more than you wanted to hear, but I wanted to give you just a sense of how challenging this has been for the task force. But I do think, as Chair Wheeler and Dr. Toller said, it has been a really important and good opportunity for the community to become more educated about what is academic health, why is it important, why is it not just on greased skids, why is there need for attention to this, and I think that is mission accomplished. I think the question of what are the most effective short-term things we can do without, frankly, over-investing in models that are not going to be the models of the future is part of where the challenge is. And I think I've seen the evolution of some of the university's proposals along that line to be, I think, a little more like thoughtful about let's take step 1 first and then evaluate step 2 and step 3. So I appreciate that.
That's fabulous. Thank you so much, Chair Malcolm. I think this is a chance for the committee to ask questions or make sure that thoughts that you have are considered by those of us on the task force and Chair Malcolm. So I'll open it up now for any comments or questions or considerations that people have. Yeah, Regent Hicks.
Chair, excuse me, Chair Wheeler and Chair Malcolm. Nice to see you again. So the question is about your customers, the legislature and the governor. So we're gonna, I love this committee for one thing. I think it's really necessary and needed, and we know we need to change, right? Or we're gonna get swallowed up. But so like after the recommendations are made, they're gonna cost money, as you said, right? And do you think there's an appetite to fund those recommendations, because it's going to be expensive, right? And I'm all in, so don't, I'm not asking that question from the other side. So.
We had some conversation about that yesterday, and as Dr. Tolar said, we heard from Governor Dayton, well, this is nice, but it's not nearly enough. You should need to spend more and spend more faster. To the chair of the House Health and Human Services Committee, Representative Liebling, who said, that's a lot of money already that you're asking for and more than we have. So somewhere in between.
She did make the comment that Governor Dayton no longer had to balance the budget. And she did. So, yeah.
Yes, she did. And he was, he responded with good, humble humor. I think it is going to be a challenge. I think, and the fact that the current, Vice President Franz, who of course, I tempted sometimes to say, so Myron, old friend, if you were sitting in your old chair, what would you think about this proposal as the finance commissioner? I know he would have some of the toughest questions. He started his presentation with reminding that, it's another favorable budget surplus. But if you've been hearing the news this morning, it's that quite the, complicated picture of another short-term surplus with the potential of a structural deficit very clearly on the horizon. So even the question of do we have a lot of money or don't we have a lot of money is where the conversation needs to start, I think. But I do think that the legislature is particularly looking to the task force for help identifying the right questions about how to evaluate the requests for funding and how do we perhaps do a better job in the future of tying funding support to more clarity of desired outcomes and a better kind of feedback mechanism about, what did the last set of investments get us, maybe differently than what we thought, and how should that inform the next steps here. I do think there's a recognition that there are gaps and that something has to happen. How big and how fast and from whom, I think, are going to continue to be questions that have to be worked through the usual decision-making process.
Thank you. Regent Turner.
Thank you, Chair Wheeler. Chair Malcolm, one concept the example I'm going to use is the consolidation of systems across the state. Not only does Dean Delaney advocate that kind of thing, everyone working together, whether it be making sure every person who wants to be a nurse is plugged in somewhere in some nursing program and some programs that don't have their roster filled, et cetera, so that we're not leaving anyone behind that has the desire to go into any of the healthcare fields. So that's huge. But the example that was given about the libraries, I don't know if you remember that, about how we have all these libraries, and I know that North Memorial had one, I know using it when I was going through nursing school, things like that, but that we have the best library here at the university, and that consolidation of that kind of resources. And so that was just an example of that kind of concept, and I think that's huge to be able to get us all working together, because right now it's, as you know, 7 different healthcare systems all kind of competing and not working together. So that theme I would really encourage.
Thank you. And that has been another one of those kind of through lines through all the discussions, is what is the right balance of competition and collaboration. And here again, we can't be an island. I mean, the nation has embraced more of a competitive model, but that does leave, lots of duplication where, from the community's perspective, resource sharing or more of a planning approach to having the stakeholders in the system talking together about what's needed and where it's needed would be really desirable. And I think there are some perhaps easier wins, such as the library example, which was offered just as an example of the broader point that you're making, that we should kind of redouble our efforts to figure out where are there opportunities for more cooperation, coordination, and collaboration. And again, I think that's, if I'm understanding the university's proposals correctly, I think there is an eye to that. Let's do some immediate things with facilities that critically need them, but let's have that community conversation about capacity overall and the models of the future and where there might be more room for collaboration.
Other comments or questions? I'm looking at you, Interim President Ettinger, knowing that you chaired and did a really wonderful job as a participant on a task force that the governor had on economic expansion. Any guidance you have, for Chair Malcolm or for us as members about how to make that the most effective for the state of Minnesota, for the university?
Well, thank you. I mean, I definitely can sympathize with the time frame you're in. We actually ended up having a 2-phased approach, so maybe that's not out of the question for your task force too. Obviously up to the governor once the first set of recommendations are complete. Agree with the model of, don't waste a lot of time and energy on votes. Rather, okay, let's get the ideas down, try to get some sort of a consensus there. But just really appreciative of the diversity of your group and the perspectives they bring. It seems like you've followed a similar pattern to the task force that Chair Wheeler and I were on, in terms of sort of information gathering first, discussion second, and now you're in a very critical and challenging recommendation phase. And so we're all eager to see what comes of it.
Thank you very much. Any other questions or areas of guidance for the task force? Regent Johnson, please.
Yeah, thank you, Chair Wheeler. I just wanted to ask if we could get some explicit kind of information, ideas about kind of health systems. When you have a highly educated, highly trained system like the University of Minnesota, we have specialists, subspecialists, super specialists. In order for them to be able to do that work and make this a really important thing, you need to have sort of feeder systems. You need to have people, primary care and others, who are seeing patients and who take them to different levels of care depending on the complexity of their problems. So I live in a system where that's all internal. We have that there, but this is a different situation. So, I would expect part of what Fairview's done or should have been doing is being a kind of a feeder system to some of that at the university. There are a lot of other health systems in the Twin Cities area. Kind of what thoughts do you have on that? What other opportunities might there be for that kind of relationship with other healthcare systems potentially? And probably for you, detail Taylor.
Chair Wheeler, Vice Chair Johnson, you are absolutely right. There is absolutely, and I like Chair Malcolm, your metaphors about an island and a river. We have a Mississippi over there that is very close, and that's exactly what it is. It has to have any high-level specialty system has to have a feeder of the referral base. What we are talking about is not doing more of the same with more money and with more structures, sort of capital heavy kind of approach. What we are talking about to be really smart about this and use the technology, as Chair Malcolm pointed out. AI is just one of them. Digital health through COVID, through our collaboration in COVID. We have learned a lot about how we assign patients to the right places. So it is coming, I think, from a different conceptual understanding, which is we are no longer looking at the slices that are lucrative. That's tempting, that has driven the business of American healthcare, in where it is. And just an aside, I had a privilege of practicing medicine in other systems, across the Atlantic that are built very differently, and they are not ideal either. There is always some. So coming to that concept, I think we don't want to do more. We want to do it differently. We want to look at the primary care, and I'm proud of my primary care physicians. We are second in the nation. Family medicine is third in the nation. We really know how to do these things. What we need to do is to answer the geographic maldistribution of the clinical teams in the greater Minnesota and the fractured environment of very saturated, very competitive market in Twin Cities by reformatting, revitalizing, almost rebuilding, parts of it, and having one single focus, which is the whole person care and the value-based efficiency. And that is the value creation that I think that the University of Minnesota, 6 health science schools and other schools, and the practice in the medical school brings to the state. So it's a longer answer to a question. The simple one, primary care is essential. It has to be renovated and revitalized the same way the specialty care has to be. And we know how to do that.
And what is our role? How is that going to happen? I mean, we have primary care that are part of the university system. I don't know kind of what the numbers are, whether, how many of them there are to help this, and then how many we might need to partner with. Not just Fairview if we maintain that, but, Hennepin County or other things. They have their own specialists as well, but I mean, some of these things do rise to the level that only a place like the University or Mayo has probably got all the specialists that you can do to do what is needed for some of these really complex care things. So, yeah.
Yeah, go ahead.
Chair Wheeler, Vice Chair Johnson, yes, you are right. I want to make absolutely clear that we, as a University of Minnesota Medical School practice, we collaborate with every single healthcare system that's in the state. It's not like we are starting anew. We have a very tight connection with Hennepin. We have a connection with VA Medical Center. We certainly work with Mayo, and we work with health partners, Alina. Fairview, obviously, is our dominant partner. We work with Essentia, with Luke's, with Centra Care. We are already there, in this way. What we need to do is to build on that, on that platform, a sort of a shared consciousness of we are not going to compete in things where it's silly to compete. Right. We will have a single lab for, say, all public health arrangements in the Twin Cities. There's no reason to compete on that. We will send people with complex cardiac to, Southdale. We will send, brain stimulation to another part of the system. So that convening of the University of Minnesota is, in my opinion, essential. And with deference to the state and help from the state, it is going to be catalytic because it will lift some of the burdens that all the healthcare systems are experiencing while enabling the patient care, having better outcomes, better harmonization of not just the social determinants of health, but medical, biobehavioral, pharmaceutical, and other ones.
Do you have any response to that idea about kind of the systems? You've worked with all the systems in the state.
I think historically it has been one of our assets, I think, in Minnesota, that we have strong community-minded health providers that have a history of collaboration. I think it's been stressed in recent years as the competitive pressures, have gotten greater, the workforce challenges have gotten greater. So I think actually we've done less of it lately. I think COVID was a real call to, kind of come back to some of that more community-focused planning, and I'm really grateful and proud of the way our health systems kind of rallied together in service of the state. But it was, pretty quick to revert to more typical competitive behaviors, I think, at the end of that, my perspective only. I'm glad, Regent Johnson, that you mentioned Mayo, because that comes up a lot in the conversations. And certainly there are ways that the legislature has already, in past years, tried to enable, incentivize, collaboration with Mayo. I think the question has been raised: could there be more? What is there another phase to collaboration? It's unusual to have two such specialized and powerhouse, highly specialized delivery systems in the same state. A great asset for the state, and a complicating factor, frankly, for the kind of how patient care is split, how payer mixes are different. But I think there's a lot of interest in just saying, okay, we've got some good bones here and some good history of collaboration. Can we refresh that conversation and see where it might go? But I just, would certainly defer to Chair Wheeler too, just about the realities of how hard it is sometimes, given the prevailing incentives, to do the things you'd really like to do.
I'm going to turn to Regent and Chair Mayron.
Thank you very much, Chair Malcolm. My head is spinning at this point. So a couple things come to mind as I was listening. One is a kind of a practical question, which is, and obviously you don't know what the report's going to look like because you haven't really started that hard work to develop the actual language of it. But how concrete do you expect your recommendations to be? I recognize you're not going to vote 75%, et cetera. But the recommendation's going to be to, whether it's the governor or the state at large, or ultimately the legislature, but to the university as well, in terms of giving guidance on at least what this august group thinks is the direction that the state should be proceeding in. So that's one question. And with that is, I am struck, at least as a layperson, that up until now, the university, its training research in particular, apart from the clinical care, is really been undertaken, the burden of that or the opportunity is been solely the university, and in our case, in partnership with Fairview. We've been the ones responsible, either through tuition or fees that we collect from the clinic or whatever, to take that money and use that money to train the workforce that then benefits the entire state. And I'm curious about whether any of the discussion or recommendations have gone to that this is not just a university burden or opportunity, or a university Fairview or with its partner, but rather the obligation of all the healthcare systems in the state to support the training and research that will then ultimately benefit what happens at the clinics, and that it's not just a university problem. I know we're looking to the state for help in this, but it seems to me that others who are sharing in the benefits of the training that we do ought to also be sharing in the investment in the training that we do. And I don't know how much the task force has touched on that.
Well, thank you, Regent Mayron. To answer your first question first, we actually had an interesting discussion yesterday about how detailed should the recommendations be. There was one point of view that, we shouldn't be micromanaging how the university does its business. We should say what are our goals, what's our wish list as a state, and let the university tell us how it wishes to respond. I was on one end of the continuum. On the other end, I think there's a desire for it to be useful for the recommendations to be much more specific than that, particularly, I think, from our legislative members who are looking for concrete enough recommendations that would help them with their task of evaluating proposals that come forward from the university or others. I think we'll be, after yesterday's conversation, what's kind of in my head is a both and strategy. I think some of the recommendations can be grouped into themes that are, more general with some very specific example recommendations underneath those themes. And to your second point, yes, the idea that there are a lot of stakeholders that benefit from the academic health mission or missions, or the tripartite mission, perhaps best way to say it. And right now, some are contributing in different ways, but not all. And that needs to be broadened out. So that there has been discussion, and I expect there will be a recommendation about ways to get all of the stakeholders participating in some way. And that would include not just the other health systems, but specialty groups, the imaging centers, the med tech companies, the pharmacy companies, the health plans. I mean, everybody that is really dependent on a robust health workforce in some way, shape, or form should be contributing. And, one can think of different tax mechanisms or financial incentives. I mean, we certainly want to credit and incentivize those who are already doing good work and encourage more of it, and encourage those who are not currently participating to do so. So how detailed we'll go into and what form of tax should that be? I don't know that we'll go there, but I think the point of everyone who benefits needs to be participating, I think certainly is on the table right now.
I do think that, our challenge up until now is, as I look at, in particular, just focusing on the medical school, who relies very little on tuition. And the idea of raising tuition isn't in anybody's, no one wants to do that. And is much of it is what drives its ability to train and teach is driven by either the fees that it's receiving or the research grants. And so it's all looking to the university to make it happen. And my hope is that embedded within recommendations is that the state needs to contribute more for the good of the state. But everybody who benefits from it, as you call it, the stakeholders, they need to ante up as well. There's finite resources. We can only look to different buckets, so many buckets, and I don't think a couple of those buckets have been adequate, at least, to further this enterprise.
And I think that's how we came to that first problem statement, that the current funding mechanism is inadequate and leaves gaps, and we'll be explicit about that point in the report.
Let me turn lastly to, because we're a little over time actually, to Regent Turner, and for the last point to make here.
Right, I'll try to make it quick. First of all, I want to kind of reiterate the whole concept that technology in the hospital workforce is more and more complex. Okay, I want to put a plug in for rural Minnesota. I mean, you talk about streamlining and doing cardiology in this hospital or that hospital. How do we need to keep on the back burner how we're going to reach Grand Marais, how we're going to reach Pipestone, how we're going to reach Baudette. And I'm talking the Four Corners here, because I've been there, all of them. And more as we consolidate where people can get the expert healthcare, it is leaving healthcare access farther and farther away from a lot of our people. And I've seen that happen. And so do you picture, Dr. Toller, like having, say you said cardiac at Southdale, but things have to be looked at in a regional approach also, so that the high tech for any body system is available to everyone within a reasonable distance.
Dean Toller, would you like to
Chair Wheeler,
brief comment?
Regent Turner, you're absolutely right. And again, I will repeat, we will not do more of the same. We will do it differently. This is how the technology is one, broadband, and how we reach, we learned this, very well during the COVID and so forth. The second is that we will look at these maternal deserts or healthcare deserts in the state of Minnesota in a different way. And I think one of the best examples I know is I charged Colonel Beelman, who is my associate in the medical school, and with a task to approximate military medicine to the medicine in greater America or greater Minnesota, because the distances are similar, the acuity may be similar. You may, ideally, you will stabilize the patient where she has been, sick or injured before you transfer her. So there is an idea of reconnecting through technology, as you pointed out, but also take the learning from the military, actually, and our experts in military, so that we actually are able to perform the high quality care that needs to be done on the point in Grand Marais, in Baudette, in Pipestone, and then transfer safely that patient where she will be treated effectively.
Great. And thank you, Regent Turner, for bringing that up. There's clearly the state demographer during one of our earlier sessions brought up the salient need for rural healthcare. And now we have opportunities to export expert care in different ways than we have before. So I just want to thank everybody on the committee for their engagement in this. I think that what we want to do as a task force is really, we've talked often about avoiding a tragedy of the commons where everybody tries to self-optimize and we don't think what we can do collectively together and how we can collaborate. And that's a theme that's coming through the task force meetings. And it's born of, really great leadership. It strikes me, Chair Malcolm, that the last time I saw you in this building was you were receiving an award for leadership from the Humphrey School. And we welcome you back, but I really appreciate your community leadership on all things and your failed retirement too, in order to do so. So thank you. Thank you very much.
Thank you very much, Chair Wheeler. Thank you all for your time and for your input, and I hope more to come. So thank you.
Great. Thank you. All right. Well, let's move on to our second item then, related to receive an update on the university's partnership with Fairview Health Services and review and act upon a resolution related to the 1997 academic affiliation agreement with Fairview Health Service. The resolution will delegate authority to Interim President Ettinger to issue the university's notice of intent not to renew the agreement. As you know, on November 20th, Fairview Health Services announced their intention not to renew the current agreement set to expire in 2026. Interim President Ettinger and Vice President Toller will provide the update of that. Interim President Ettinger, the floor is yours.
Thank you so much, Chair Wheeler, Vice Chair Johnson. So as you just mentioned, we were indeed notified prior to Thanksgiving that Fairview was electing not to renew our current agreement, which runs through the end of 2026. So as a reminder, in 1997, the university entered into a 30-year academic affiliation agreement with Fairview Health Services. Through that affiliation, the university's East Bank Hospital was combined with Fairview's community hospital facilities on the West Bank to create an academic medical center, with Fairview becoming the university's principal clinical partner for the advancement of the university's health-related academic mission. In 2018, the University of Minnesota Physicians, and Fairview built onto the 1997 academic affiliation agreement by entering into additional agreements that formed the mHealth Fairview Joint Clinical Enterprise. As we have previously said, as has Fairview, that our current agreement would need to change for the future. So the notice from Fairview, from our perspective, merely affirmed those intentions. With Fairview having given its notice, a reciprocal notice would serve to confirm our commitment to engage with Fairview on refashioning our relationship for the future. As you will see from the resolution before you today, we are focused on what is best for the public health in the years ahead and how to have our mutual notices spur good strategic planning. Accordingly, the resolution is written to give me the discretion of when, between now and December 31st, to give our notice to Fairview so that it can be framed to fit the dialogue that is ongoing and be matched with the appropriate messaging. It's important to note that both the notice delivered by Fairview and the proposed resolution do not affect the clinical partnership we share with Fairview today and the world-class care that patients are receiving in mHealth Fairview hospitals and clinics. Those will certainly continue at least through the end of 2026. I do want to take a minute, though, to talk about timing with the committee. If this was merely a private transaction between the University of Minnesota and Fairview, given that the structure was allowed for a 3-year notice provision, honestly, our perspective and Fairview's is we'd have probably a year to be able to work on new structures, new negotiations without really having any risk to the current model going forward. But in the backdrop, you heard Chair Malcolm from the task force mention that even though they know explicitly that Fairview is not part of the direct mission of the task force, it just inherently kind of waves over. And indeed, our own doctors, our own nurses, our own patients, the public in general is keenly interested. Okay, if you're both giving notice and the old deal is off, what's going to happen in the future? Secondly, the task force recommendations are due January 15th. The legislature starts meeting at the beginning of February, and they will be meeting until May. So if our posture with Fairview is, well, okay, we don't have to talk till October, we would be missing this really important moment here. The Fairview relationship is not the entirety of what's going to be recommended or what the legislature is going to look at, but it's certainly a piece of it. And then lastly, the priorities that this board has given me at our July retreat earlier this year was that this was one of my priorities. And I'm the interim president. I mean, my contract can move. My contract right now is until June. It could slide a couple months depending on what happens with the search. But clearly, the board has said to me, no, this is not something we're just going to punt to the new president. You need to work on this with your team. So long story short, the time is now to get moving with these conversations. We are now earnestly exploring the next phase of our partnership with Fairview. Just yesterday, we issued a joint statement with Fairview confirming that we continue to work together toward a new reimagined partnership, and we made tandem requests to the task force. Our team and I have been engaged in active, frequent conversations with Fairview to define our future relationship. Simultaneously, as we just discussed in the previous agenda item, we continue to participate in critical discussions and planning with state leaders that will help shape the future of Minnesota's healthcare. So at this time, I'd like to turn it back over to Dr. Tolar to continue the update for the committee and provide further insight.
Thank you, President and Chair Wheeler, Regents. As President Enter explained, this resolution gives him an authority to formally give notice to Fairview Health Services and equally importantly expresses our desire and intent to work with Fairview to design a better path forward that recognizes the progress we have made and the financial realities that we live in, and the obligation that we all have to the state of Minnesota and the public question that is always in the background. The joint clinical enterprise that's what we branded mHealth Fairview some 5 years ago was a major step forward for the medical school and the medical school practice, the physicians, for several reasons, but mainly because for the first time we had academic physician leadership in the system in key roles such as chief quality officer. Quality and safety obviously is paramount in everything we do. And because the financial terms of that agreement allowed us to pay nationally known docs, what I call franchise players, the ones that are known not only the best, but they can build a team around them to support near level of our peers in the academic support that we receive annually, and begin to align around the idea that academics, the research, education, and the care, one composite, should grow across the full Fairview system footprint. Now, the outcomes, we are, and I will never tire of repeating this, number 8 public medical school in NIH research funding. That was the goal of this board. This has not happened in decades. And we now are in that privileged position. We have skyrocketed in quality and safety. We went from the very low, bottom quartile to the top quartile. We earned an award from the Vizient, which is the firm that controls the quality and safety rankings. We have grown in the market positions in the very dense, competitive system in the Twin Cities. And through the strength of the brand, we have improved the quality, the rankings of the hospital. The University of Minnesota Medical Center Hospital is number 2 in the Twin Cities, number 4 in the state of Minnesota, and we have extended the access, the equity, the productivity, all the things that we all care about. At the same time, we do know that the financial realities are difficult. Some of you mentioned how clinical revenue is very different from clinical care. And the business of healthcare is very different from healthcare itself. And when we began these negotiations in summer of 2022, we were clear that we want, as partners in ML Fairview, be a part of the solution and part of the path to the sustainability. We have taken a few detours since then, but with President Edinger's leadership and diplomacy, we are back to what I believe are earnest, good faith efforts to understand the needs of all organizations involved. For us, the public interest, the service to the state, is our primary fundamental responsibility. To meet that mission, to support our faculty, students, and staff, to best serve the patients, we need a system. We need an academic health system, not an island, not a ivory tower of any kind. And we have realized through the issues over the past year that has to be the ability to ensure that our University of Minnesota Medical Center is a home for excellence centered on the academic mission. Now, that mission has to be here for the benefit of all patients, not just the patients in the Fairview system. We combine, our effort with multiple healthcare systems and hospitals in the state. So we need to have the ability to make the financial, operational decisions, the decisions on investments, on care delivery, on behalf of the public interest, on behalf of the patients that we serve. So I can tell you that, to your point, President Edinger, too, that the faculty is, at the same time, of course, they are watching what's happening, but at the same time, they are energized by the ability, by the opportunity to be the ones who will build the future of the health in the state of Minnesota. And they are proud of what they built with Fairview's collaboration, of course, partnership, what they have built in the joint clinical enterprise, and they now do understand much better the economics of healthcare and are able to function in these leadership roles. So we are deeply committed to the mission, and we will deliver as we have done before. We have self-selected into this group that is, as Regent Johnson said, committed to excellence in care, eager to advance the new care models, and dedicated to each patient, to the whole person health, not just the one lucrative slice of it, and collaborate with our colleagues in big and small ways. So it's no secret that the relationship has been strained. It's a function, in my opinion, of any complex and complicated affiliation. And at the same time, our physicians, our teams, and Fairviews continue to work every day together and continue to work well together. That's also very important because we day in and day out, I get these dashboards every morning. We provide high quality care, experience to our patients, training the new learners, and advance the translation of research, sort of domesticating, humanizing the science that we bring into the clinical care. For us, the sooner we have clarity on our path forward, the better. The better is going to be the stability, better is going to be the pathway in front of us. And even though there is a great deal to work through, and I'm grateful for everybody who has helped, I like to see this again as an opportunity to determine what the future is going to be, because the future has not been built yet, and we are a part of being the builders of the future. We are, as we serve the state and the University of Minnesota, and I'm grateful to all for that open door.
Thank you. Thank you, Dean Toller, and thank you, Interim President Edinger. Before we move to a discussion, I'm wondering if I can call for a move to approve the resolution related to the 1997 academic affiliation agreement with Fairview Health Services.
So moved.
Second.
And a move and a second. Any discussion? And first of all, I'll say I appreciate that what was won't serve us into the future and what will be. So I appreciate the ongoing conversations and also have to recognize the progress that was made, from a quality standpoint, from a ranking standpoint, from all of that that was made, and am grateful that the discussions are ongoing in a productive way. A question I have is related to a timeline. As you said, Dean Toller, the sooner the clarity, the better, right? And I think that's a lot of, for retention and recruitment of some of the talent that we have, for a lot of stability reason, that's true. Is there anything on the time horizon that would say, President Ettinger, other than your tenure, that would push the timeline so that we can get to a sooner rather than later resolution in terms of a partnership?
Thank you, Chair Wheeler. No, clearly, if we, even the tenure quote was to kind of draw it in to not the fall, but realistically also, I mean, if we don't emerge with some sort of understanding until June, there goes the whole legislative session and they don't know what we're doing. So clearly, the goal is to work earlier on that. We are having earnest discussions right now. It's a balancing act between, it's a very complex partnership. And so you could quickly reach certain understandings, but you may be making mistakes if you're doing that. And then secondly, it's inherently bilateral. And so, we can control what we think are good ideas. The Fairview system has to weigh in and decide what they think are workable ideas. And so, but we hope that dance will occur over these upcoming weeks.
Okay, great, thank you. Are there other comments or questions? We've had a move and a second to approve the resolution. All in favor? Aye. Any opposed? Great. That motion passed. All right. There being no additional business before the committee, I think the committee stands adjourned. So thank you very much for your attendance and appreciate all the work that's being done to further this for the university and the state of Minnesota. Thank you.